Peter's going to be talking about how do we think about measuring healthcare spending in Medicare Advantage encounter records when they don't include payment data. So I'll let you take it away.
Yeah, sounds good. So the objectives of this segment are to sort of think about, when do we want to calculate and look at healthcare spending, and to understand some of the limitations of Medicare Advantage Encounter Data for understanding payments, and then just help start you brainstorming possible approaches for constructing metrics of healthcare spending as you're working with a Medicare Advantage Encounter Data. So I guess just to start, there are different types of questions that you might be wanting to study once you have access to Medicare Advantage Encounter Data. So you might want to know, how much does resource use differ between Medicare Advantage and fee-for-service Medicare enrollees. You might want to compare resource use and spending between different types of Medicare Advantage plans. So for example, HMO plans versus PPO plans. And then you might also care about how does Medicare's spending on healthcare for fee-for-service beneficiaries differ from what Medicare Advantage plans spend on healthcare for Medicare Advantage enrollees. And so the key underlying issue here is just how healthcare expenditures are computed. So when we think of total spending, total expenditure for a given service, that's going to be equal to the price per unit of that service by the quantity of units of that service. So in fee-for-service Medicare, the prices are very knowable. So they're set administratively by the Centers for Medicare and Medicaid Services. You can see the prices on fee-for-service claims data, and you can download fee schedules from the Medicare website. So that is quite transparent. In contrast, the prices for Medicare Advantage are negotiated between the Medicare Advantage plans and healthcare providers. And the key issue is that in the encounter data, you do not observe these prices. You can observe the utilization, but not the prices. So you have the quantity, but that's it. And there are other data sources where you are able to see prices for Medicare Advantage plans, and there's evidence that suggests that the unit prices are lower for Medicare Advantage relative to fee-for-service Medicare. There's other evidence that suggests they're similar, but the key issue is just when you're working with these data, you're not going to know the price. So the key strategy that we're going to suggest today is that one way to account for the fact that you can't see the Medicare Advantage price is to kind of impute a price using the fee-for-service price, because we do observe the quantities and the types of services that enrollees are receiving in the Medicare Advantage encounter data. And we know the prices that are paid for each service by fee-for-service Medicare, and we can see that information, like I mentioned, like in these publicly posted fee schedules. And so the solution is to, take these publicly available prices paid by fee-for-service Medicare and apply them to the utilization information that you see in the Medicare Advantage encounter records. And so what this does is it creates a measure of healthcare spending that just standardizes or holds constant prices to fee-for-service levels. And in fact, our fellow ResDAC faculty member, Jia Zheng, also published a paper in Health Services Research this year that sort of refines a strategy for doing this. And I think it's definitely worth checking out that paper. So it's worth thinking about, though, like, what are you getting if you're comparing spending in Medicare Advantage versus fee-for-service Medicare, and you're using fee-for-service prices? Like, what, like, how do you interpret that difference? And so holding prices constant at the fee-for-service level essentially provides a method of weighting different types of services based on the intensity of those services. And so it allows you to say something about how resource use differs between Medicare Advantage and fee-for-service enrollees, or comparing resource use between different types of Medicare Advantage plans. And specifically, what you're able to answer is the question: if Medicare Advantage providers were paid at fee-for-service rates, spending would be this. And so really what you're getting at here is, you're able to say something about, the extent to which differences in utilization of healthcare between Medicare Advantage and fee-for-service, or fee-for-service, or between different types of MA plans, how utilization drives differences, but you can't say anything about the prices. Let me just look at the chat here. There seems to be a question. Oh yeah, that's a great point. You can use the standardized price approach and compare it to bids. Yeah, good point. So the key question we can't answer is, how much does Medicare's total spending on healthcare for fee-for-service differ from Medicare Advantage plan spending on healthcare for Medicare Advantage, because we don't have the prices. So there are some key considerations for when you're using fee-for-service prices and applying them to Medicare Advantage. So one key issue is just that the unit of payment. So like, what are the relevant units when you're thinking about a quantity varies across service types. So the question of like, what services are covered by a given payment. And so Medicare fee-for-service is paying for hospital stays. They're paying Medicare fee-for-service is paying for each day in a skilled nursing facility, and it's paying for each service provided during an outpatient physician visit. And so one tricky thing is that Medicare Advantage plans don't have to pay for services using the same units. So for example, in home health, fee-for-service Medicare is paying 30-day episode payments, right? Episode-based payments. Whereas my understanding is that often Medicare Advantage plans are paying per visit rates. So it's just a different measure of quantity. And so it's really important when you're thinking about applying these fee-for-service prices to Medicare Encounter claims that you're using the same units of payment. So you're converting to a common measure of quantity across the two types of Medicare. Other issues thinking when you're using fee-for-service prices. So one issue is that Medicare is paying different prices for the same service in different contexts for fee-for-service patients. So for example, the actual payments that Medicare is paying providers may vary based on the wage levels in a given area. There are different payments, for example, to hospitals that serve more lower income individuals. And even, different types of hospitals have different types of payments. So critical access hospitals are receiving cost-based reimbursement, whereas acute care hospitals are receiving prospective payments. And so the one question is how do you sort of account for these different levels of payment across different facilities that are the same type of facility, but their wages differ, for example. And so one approach to this issue is just to take the base payment rate for a certain type of facility. So for example, if you are looking at hospital payments, you take the base payment rate for a certain type of hospital admission, and you're not incorporating any additional payments due to a certain area having higher wages, or that type of hospital serving a high number of lower income individuals, or having a residency program. And so in this way, you're basically really just using a very standardized price measure. So in her recent paper, Jia Zhang and co-authors kind of went beyond just using a base rate and apply sort of a facility type adjustment factor. So basically sort of says, like, this is, if you're thinking about acute care hospitals, you would basically be saying, once you incorporate all of these adjustments for area wages and residency programs and serving low-income patients, the average adjustment over the base rate in a given year is 10%. And so basically you take the base fees, you apply this adjustment factor, and then that's your standardized price. So I definitely encourage you to take a look at her paper as you're thinking about how to do this. Okay, so there was a question here about how and where can you get these base payment rates? So for example, it's all on the CMS website. So for example, to obtain, we'll be talking about hospital payments in a slide or two. So if you wanted to know, like, what is the base rate for each MSDRG, that is posted in a spreadsheet on the final rule for the inpatient prospective payment system for each year on the CMS website. And then there are similar fee schedules posted for the physician payment system and for skilled nursing facility payment. And so all that information it's a bit, you have to kind of wade through like a number of spreadsheets, but it's all posted. And we do have some links on this on these slides that you can refer to as well. Okay, so let's talk about a couple of examples. So yeah, the first example is applying fee-for-service prices to Medicare Advantage hospitalizations. So fee-for-service Medicare, as we've discussed, pays a fixed rate for each hospitalization, and so the base level of payment is determined by a base payment rate, and then the relative weight of a given Medicare severity diagnosis related group. And so you would be assigning the corresponding rate for the relevant MSDRG. So as an example, a Medicare Advantage hospitalization in 2022 would have a base rate of $6,595. So I added there the base operating rate and the base capital rate, and then the relative weight for MSDRG 469 is 3.0859, and so you would get this base rate of $20,352 for a Medicare Advantage hospitalization for DRG 469. And then if you took this further and wanted to apply just the average, some average of adjustments to further inflate or deflate this number, you could take Jia Zhang's approach and find the sort of average of adjustments across hospitals and then apply it to this number. Okay, A second example would be applying fee-for-service prices to Medicare Advantage skilled nursing facility stays. So, so fee-for-service Medicare pays a fixed rate for each day of a skilled nursing facility stay, and so now the way that these payments are assigned is based on a relatively new payment model that was adopted in 2019, which is called the patient-driven payment model, the PDPM. And it's actually kind of a complicated model. So there are separate daily base rates for different that are each adjusted for case mix, and the different categories are nursing, physical therapy, occupational therapy, et cetera. They're all listed on the slide here. And so, and you can read more about this payment model. I just put the link to MedPAC's SNF Payment Basics article. But just to give you a sense, like a 10-day, if you added up the daily base rates for a given skilled nursing facility stay, they total up to $434.95 a day. So if you were just applying the base rate to a 10-day skilled nursing facility stay for a Medicare Advantage enrollee, you would calculate that the standardized spending would be $4,349.50. Now, I mean, that's basically just assigning the price for sort of the base level of needs in all of these different categories, so nursing, physical therapy, et cetera. The issue there is that you're sort of not incorporating information about the different, a given patient in Medicare Advantage like may have different nursing or physical therapy needs. And so if you wanted to take this further, what you could do if you had access to the minimum data set, which is the data that includes assessments of patients admitted to nursing facilities. I mean, there are assessments for Medicare Advantage enrollees, so it is possible that you could use those assessments, the assessments that are required for everyone, and create a more refined per day rate based on patients' functional needs and therapy needs at their initial assessment. But that would be a pretty involved calculation, but it's definitely theoretically possible. Okay, there's a question about, should this calculation consider inflation rate if looking over years, or is this incorporated in the weight? That's a really good question. I think that, I mean, it wouldn't be incorporated in the weight, but it would be incorporated in the base daily rate. So for example, thinking about hospitalizations, that base rate that each year that is set by CMS is going to account for inflation. But I mean, that's a really interesting question. Yeah, so it's accounting for inflation. So what actually you might want to do if you're looking at a long time series is you might actually want to you probably want to account for inflation by I would use the CMS payment rates in each year to calculate nominal payments, and then use the CPI to create real payments and real dollars that kind of hold have a constant dollar value each year. Does that make sense? Rafiq, if you have questions, let me know. Yeah, thanks, Liana. That's good to know. So a third example would be applying fee-for-service prices to physician visits. Fee-for-service Medicare does pay physicians based on individual services. Now it's kind of complicated at the end of the day based on the quality payment program because there are adjustments based on, you know, if you either you're participating in an advanced payment program like a risk-bearing ACO, and you get a bonus, or you know, there is the MIPS kind of pay for performance program. But I would maybe, if you're trying to create sort of standardized prices, I might ignore that information and just use the payment rate that is published in the Medicare physician fee schedule. So there is a base level of payment that is assigned based on the relative value units and other information for a particular service. So you can find the payment rates for each HCPCS code in the Medicare physician fee schedule. So as an example, an evaluation and management visit in a physician's office with a HCPCS code of 99213 in 2022 has a non-facility price of $92.05. So you could assign that rate to you know, E&M visits that you see with 99213 for Medicare Advantage patients also. So so I think that's like a, you know, that would be a pretty, we do have HCPCS codes in the carrier files, in the Encounter carrier files. So this would be, you know, not too hard to implement. And just to kind of note that there are other settings in fee-for-service Medicare that have other types of units of payment. So as I mentioned earlier, home health is paid for on a for 30-day, Medicare pays home health agencies for 30-day episodes of home health care. And so that's like an episode-based payment. Hospital outpatient departments are paid on a per service level based on an ambulatory payment classification fee schedule. Ambulatory surgery centers are also paid on the APC fee schedule, and durable medical equipment and clinical laboratory services are also paid on a HCPCS level. And so that's you know, pretty you know, like conceptually not too hard to implement in the Medicare Advantage data. I will say, I think this approach is makes sense conceptually. If you talk to Jia Zhang about her work in the HSR paper, it gets pretty complicated to implement and practice, but I think her paper definitely includes some lessons learned that could help you get started. All right. So yeah, here are some references. This is her paper that I think is worth checking out from 2022. Here are some links to like the inpatient prospective payment system final rule. This is the CMS physician fee schedule lookup tool, and yeah, definitely some really useful information on those pages. Any questions on this?
I think you were able to see all the questions that came through chat you answered. If anybody has any additional questions, feel free to ask them now.